Hello everyone, welcome to JFK University Medical Center Health Spotlight. I'm your host, Dr. Kishore Ratkalkar, pulmonary internal medicine physician, JFK University Medical Center, Medical Associates of Central New Jersey, and Hackensack Medical Group. Today's topic is coronary disease, which is an important topic, and I have an expert to discuss coronary disease with you all. Is Dr. Saleem Husain, a board-certified interventional cardiologist, director cardiac cath lab, JFK University Medical Center. He's also director of chest pain center at JFK University Medical Center. He has been in private practice in our area in Central Jersey for last almost 30 years. He is a dynamic physician who regularly does interventional cardiology and helps a lot of our patients, especially in our community. Welcome, Dr. Saleem Husain.
Thank you for inviting me this morning.
So we'll start with some few questions for you. And one of them is, what is coronary disease? And then I want you to discuss the incidence of heart disease, especially in the South Asian population. And thirdly, what are the risk factors that predispose our South Asian people, especially for coronary disease?
Sure, thank you. So coronary disease is actually a built-up of plaque. A plaque is a component of cholesterol and calcium that builds up in the arteries as we get older, as well also with risk factors. As time goes on, the plaque builds up and causes obstruction in the arteries, and arteries are really like pipelines that supply the blood to the heart. Eventually, the blockages become more than 75% and then cause obstruction and symptoms. Sometimes they're 100% occluded because acute clot forms, and then you end up with a heart attack, and that's usually with the natural course of coronary disease.
What is the incidence of coronary disease in Asian population?
So it's very prevalent and it's very high, especially in the Asian population. A lot of this has to do with genetics. The incidence of coronary disease is very high in the population because of family history. Family history plays a very large role in terms of coronary disease. The other risk factors, which are also very prevalent in this population, is diabetes. The incidence of diabetes is very high in the South Asian population. Coronary disease is still the #1 cause of death in the United States in terms of death for diseases.
So in the risk factors is also high cholesterol and all other factors and lifestyle issues too, right?
Correct. The risk factors that we consider are hypertension, high cholesterol, tobacco abuse is one of the other factors, which is still prevalent in the Asian population, unfortunately. And the key two risk factors is what I mentioned before, is the diabetes and the family history. They tend to be the #1 cause. Third would be tobacco abuse, and then other ones would be down the line.
Okay.
Obviously, cholesterol is the key because that is what produces the plaque.
So what are the symptoms of coronary disease?
So there are classic symptoms. The classic symptoms is usually chest pains, and the pain can be located on the left side of the chest, mid-sternal area, which is in the middle of the chest. The pain is usually a very pressure nature, like somebody sitting on your chest. It's described as an elephant sitting on your chest or a truck sitting on your chest. They usually have associated symptoms with it: shortness of breath, meaning they can't catch their breath, or diaphoresis, meaning they break out in cold sweats. The symptoms usually occur when they're doing activities and they get better with rest. So when they're exercising or walking, the symptoms will occur. When they're resting, the symptoms regress.
So is there a disease entity called silent coronary disease, especially somebody who has diabetes?
Correct, exactly. So classic symptoms are those. They're also very atypical symptoms. Some of the atypical symptoms tend to occur more commonly in women as well as diabetics. Women don't necessarily always get chest pains. They can get other symptoms such as jaw pain, nausea, GI symptoms, can be also anginal variants, as we call them. And like you said, basically 50% of the people with diabetes will end up with silent heart attacks, meaning they've had a heart attack and they never know about it. And that's one of the reasons why diabetics need to be closely screened for heart disease on a regular basis, especially if you've had long-standing diabetes and are insulin dependent.
So that is really a major risk factor for coronary disease. So for our viewers, what is a typical symptom of heart attack or myocardial infarction?
So it's what I described before. It'd be chest pains, and the pains are basically unrelenting. In other words, they continue. In other words, you stop walking, you stop doing activities, and you continue to have the pain. If the pain lasts for more than 10 minutes, then it's a key point that something bad is going on, that you may be having an acute coronary syndrome, which is either a heart attack or an artery that's severely blocked. At that point, you should seek medical attention right away if the pain does not go away. You shouldn't sit and wait to see if it goes away. If it's more than 10 minutes, it's usually the cutoff that we call.
Okay.
And
So
the heart is really one of the only organs where the heart muscle does not recover once it's damaged. So usually by 1 hour after you have the onset of these symptoms, probably about 90% of that myocardium that was involved is damaged already.
so the heart muscle is not reversible if it's longer.
Correct. So there's no reversibility. In other words, you rupture your bicep tendon, you can recover it by doing physical therapy. Muscle regrow or regrowth. The heart muscle, unfortunately, has no reversibility once it's damaged. And once it's damaged more than 90%, you've pretty much lost function of that part of the heart.
Other than symptoms of chest pain, what are the other symptoms that they should watch for?
So other symptoms be GI symptoms, symptoms of nausea, vomiting that occur with activity and relieve with rest. You know, people say I have regurg. Regurg could be also a sign of angina in a lot of these patients. A lot of people have jaw pain going up to their jaw when they have these symptoms there. You know, they walk, their jaw starts feeling tight. Arm pain, specifically the left side, when they have pain radiating down the left side. The heart itself really has no nerve endings, so because you hurt in one position does not mean that your blockage is there. So what it does is send signals to the rest of the body, to the diaphragm, to the jaw, to the shoulder, saying that I'm in trouble, please help me. So it's the heart's way of mechanism of telling you there's something wrong.
Okay, thank you. We'll return after a short break. Please stay tuned. Thank you. Welcome back to our episode. I'm here with Dr. Saleem Husain, interventional cardiologist, and we are discussing coronary disease, an important topic which affects pretty much a lot of people, and it is one of the #1 cause of morbidity and mortality in the United States. Dr. Husain, now you are an expert, you are an interventional cardiologist, and you see a lot of it. So what are the tests that you recommend patients should have if they have warning signs of coronary disease?
So our first test we always do on patients is a simple EKG. EKG sometimes helps guide us. If it's normal, it's helpful. If it's abnormal, also helps us focus on how to further manage this patient and look for other testing. The next step is usually looking for an echo. Echocardiogram is an ultrasound of the heart to see if the heart muscle is okay, if there's any damage to the heart muscle, if the valves are functional. And then the third step would be a more evaluation to see if there's an evidence of coronary disease. There's multiple modalities now available for looking at coronary disease, and it really depends on how symptomatic the patient is. If the patient is having symptoms that are more frequent, occurring more frequency, and more intensity, then I think you'd have to take a more aggressive route. And that would involve like an angiography or a cardiac CTA to definitely rule out underlying coronary disease. A cardiac catheterization is where we go up to the heart invasively through the wrist or the femoral artery and look at the arteries themselves and see how bad the blockages are. Usually screening tests that we do are stress tests, calcium scores, and cardiac CTAs. So calcium score is a good screening test that we've been utilizing for the last few years, especially in a younger population who comes into the office, says, I have a family history, my cholesterol is high, what do I need to do? Do I have a possibility that I have coronary disease? A calcium score is a very simple test, takes 5 minutes to do, and you can get it done at many facilities.
Sure.
It's very helpful in deciding how to manage these patients. If the calcium score is 0, that means your incidence of having coronary disease is 0.01%.
That's great.
Yeah.
So the incidence grows up when it is in the moderate range, say about 400 and above.
Correct. So above 100 is where you get into the gray zone, and then above 1,000 is considered high risk.
Right.
And if you're under 100, there's your sort of mild risk. If you go above 100, that's when you should be starting to be treated aggressively. So that means you should have your cholesterol very aggressively treated. If you're diabetic, the diabetes needs to be very aggressively treated. And all your risk factors should be, if you smoke, you should stop smoking, obviously. So that's a very simple screening tour. Then if your calcium score is high and so forth, then you can do a stress test. And the stress is a physiological test to see if you have blockage that are significant that will cause ischemia or symptoms of ischemia. And that would be another test. Other tests you could do is the cardiac CTA. It doesn't really tell you the physiology as much, but it tells you about the anatomy.
Anatomy, right.
And the anatomy is helpful to know because that will help guide, if there is severe blockages, and it is significant, then you need to be treated. If it's moderate, at least you know what the plaque burden is and how to treat it.
So those are the invasive tests and more advanced tests. In a general population, when do you start doing EKGs?
So I think if you have risk factors for heart disease, in other words, family history of coronary artery disease less than age 65, if you have diabetes or hypertension, you should get an EKG on a yearly basis. And if there are any EKG changes over that one period of year, then that means that something has happened or you should be screened further for heart disease. The general population, screening with a stress test and stuff is indicated for diabetic every 2 years, obviously. 1 to 2 years is what the recommendation is. If you're not a diabetic and you're asymptomatic, then you can probably hold off for every 3 to 5 years if you have family history or so forth. But just simply screening everybody is not really, anything that's required. It's usually people who have risk factors, and the risk factors are what we mentioned.
So a regular stress test is what you would recommend for somebody who has risk factors or diabetes.
So a person has low risk, in other words, they have one, so if they have only 1 or 2 risk factors, you can do a regular exercise treadmill stress test, and the EKG is normal and you have a good functional activity. If you can do more than what's called 6 METs on the treadmill, your prognosis is good. That means that should be a good screening test. If you have risk factors such as diabetes, smoking, or family history, and you have more than 2 risk factors, then probably doing a more diagnostic test such as a nuclear stress would be the way to go then.
Okay, I just want our viewers also to know that nuclear stress test is a great stress test, but it is not conclusive as you're doing a cardiac catheterization.
Correct. The accuracy of a nuclear stress is about 85%. Regular stress is about 70%. Cardiac catheterization is the 100% gold standard.
That's the gold standard.
That's the gold standard still.
Right. So do you recommend EKGs at age 50, or what are your thoughts on that?
I think about 45. 45 is a good age to start doing EKGs, especially if you have risk factors. Yeah, routinely, yeah. And if you have no risk factors, then probably 50 is a good age.
50 is a good age. Okay. So it's very important to understand to all our viewers that these tests will be, offered to you by your primary care doctor when you see him. If there are any abnormal EKG or some changes, or you have risk factors, you can consult a cardiologist. And Dr. Saleem Husain, interventional cardiologist who can, if there is an abnormality, then we recommend cardiac cath, etc., to help those patients. So this calcium scoring has taken up a life of its own. And there are some physicians that I know, they have some difficulty with this calcium scoring because the accuracy of it as to whom we should screen and whom we should not be more aggressive in doing any procedures. As you said, it's over 1,000 is a red flag zone.
So, calcium score is very helpful. For example, somebody who comes in who's 35 years old to your office, has a very high cholesterol profile, has a family history, and he wants to know if he should be taking medication for his cholesterol.
Right.
And, he's very resistant on starting meds. He doesn't want to start meds because he says, I'm too young. Right. And this is the type of ideal patient that you want to do a calcium score on. The person who's 60 years old already has 2 stents in his arteries and has diabetes, there's no futility in doing this.
Right.
This is a nice screening test for a younger person, maybe even 45, 50 who has no risk factors, and his cholesterol profile comes back, his LDL cholesterol is high. And his primary doctor says, you have to take meds. And he's like, I don't want to take meds. So doing a calcium score is very useful. So if your calcium score is 0, then you can say, okay, you know what, I don't need it. But if your calcium score is above 70, you should consider, I mean, that's my cutoff is 70.
To be aggressive in management.
Aggressive, or start thinking about taking statins. Over 100, you should definitely start taking statins.
Statins, right.
And then if it's over 100, or if it's in the 400 or 500 range, then you need more screening. Then you need to get a stress test. You need to do either a cardiac CTA or look for
do something, yeah. Yeah, appreciate that. Thank you so much, and we are going to take a short break. Please stay tuned. We'll return in a few minutes. Thank you. Welcome back. Your host, Dr. Kishore Ratkalkar. I'm here with Dr. Saleem Husain, interventional cardiologist, JFK University Medical Center. He's also the director of Cardiac Cath Lab and Chest Pain Center. Dr. Saleem, welcome back.
Thank you.
Dr. Husain, sorry, my correction.
Saleem is good.
So now let me ask you, what are the preventive measures, which is the key to prevent heart disease? That our viewers should know and abide to so that they don't get into trouble.
Sure. So there are some modifiable risks. Obviously, there are certain things you cannot modify. Family history is one of the unfortunate ones you can't modify.
Genetics.
Genetics is really the key. So if genetics you can't really modify. The things that are very modifiable, and the easiest one is smoking. If you can stop smoking and avoid tobacco of any type, that is one of the major risk factors which will prevent you from having progression of heart disease or heart disease. The really other key points are going to be diabetes and hyperlipidemia, which means cholesterol. So cholesterol is very important because really when we started out the talk, we talked about what is the plaque, what is coronary artery disease. It is really cholesterol built up in the heart. So if you aggressively treat the cholesterol, if you can get your what's called the LDL cholesterol, which is the bad cholesterol, down below 70, you will probably have stabilization, what's called a plaque or a regression of plaque, and that's really the key factor. So if you look at two people who have similar twins, who have identical twins, they have modifiable risk, meaning their cholesterols are high. One tries to attempt by doing it with diet alone, and the other one uses statins, which is medications. The one who uses statins has less incidence of having coronary events, meaning heart attacks, strokes, and death. So that is one of the few drugs that's actually shown favorable results over the last 20, 30 years. The other thing is obviously diabetes. You know, aggressively treating your diabetes. It's another disease which is modifiable, but unfortunately, if you have diabetes, you have diabetes, but you can modify your lifestyle. You watch your diet. The third thing in our Asian population, unfortunately, is our diet. We tend to eat a lot of saturated fats,
right.
And one of the things I go to the store and what I see online, I see everybody buying ghee still, you know, and ghee is really just free radicals of cholesterol.
Yes,
that is the worst cholesterol that worst type of fat you can eat of any.
Absolutely.
So that is one of the things, unfortunately, we have on our diet. The other thing is that our population tends to be more vegetarian, so we tend to eat out at certain foods like pizzas and stuff, which is again, same thing, it's a saturated radical, saturated fat. And these are the things that all increase the risk of having heart disease.
So eating healthy is critical, apart from all the other things that you said. And you said about smoking, which is important. How about stress, alcohol, and physical activity?
So exercise obviously helps because that helps modify your risks. You know, it helps with weight loss and weight control, helps with your cholesterol management, all these other factors. Obviously, meds are not the cure. You have to modify your life. In other words, a med is not the cure. A med is not going to cure you and make you better. And alcohol obviously plays in it because it raises your cholesterol. Alcohol leads to obesity, other complications, other organ damage. So that's one of the bad things also.
Stress is very important, that they need to reduce their stress.
Correct.
So that, you know, it doesn't get into, the lifestyle is quite important.
So stress is important. Obviously, stress will lead to other problems too, eating more, eating healthy, drinking, smoking, all those things.
So what is the definitive treatment, apart from preventive? for coronary disease?
So initial
Medicines,
try,
and all
So
that.
initial try is medical therapy, unless the patient's having unstable symptoms, meaning they're becoming more frequent and occurring in longer durations. Initial treatment options is medications. Medications are usually what's called calcium channel blockers or beta blockers or nitrates we usually try. If that doesn't really cure or alleviate some of the symptoms of angina, then you proceed with next testing. In terms of prevention, the most important med is what I talked about, is statins and cholesterol medications. They're really the key in preventing coronary disease, and that's the most important things, I think, in terms of drugs that we have. If they fail, then we have other options, and then we have to go to our gold standards. We have to go to angiography and visualization.
Mm-hmm.
Obviously, you could do a CTA, which is a CAT scan of the heart, and look at the arteries. But again, it's a diagnostic tool. It's not a therapeutic tool. Still, it's not 100% accurate. The accuracy of them is about 90% to 95%. Okay. So it's still not 100%. The gold standard is still cardiac catheterization, is where it's an invasive procedure. And what we do is actually visualize the coronary arteries and see how severely they're blocked.
And then you do stenting and all that.
Correct. So usually when we get to that stage, I usually tell my patients that there's a 70% chance you're going to need something done, meaning you'll need some type of coronary intervention. In this day and age, I mean, over the last 30 years, we've had such dramatic changes, new technology that really is becoming standard care now. So we can treat most of the diseases with stents and balloons, and now we have other things, that lithotripsies and drug-coated balloons that we have available now to treat patients as well. So the options there. There's always about a 3 to 5% chance that you need open heart surgery.
Yeah.
So open heart surgery is still there. The incidence of open heart surgery is less than it used to be. Obviously, that's left for patients who have very complex lesions, who have multiple lesions.
I know, not amenable.
Who are not amenable, whose hearts have already been damaged and weak, or patients who are diabetics, who are insulin dependent. They tend to sometimes do better with surgery.
So the last thing I want to ask you, aspirin, because it's very important for all our viewers to know, and it is the most commonly drug which is available over the counter. So there are some controversies, so can you tell our viewers the use of aspirin? So
it changes every week.
I know, that's why I brought it up.
So for right now, the recommendation is aspirin is not recommended unless you have documented coronary disease.
Right.
In the female population, actually it's higher risk to use aspirin, but there's a higher incidence of bleeding and CNS bleeds or intracranial bleeds with aspirin. So it's not really recommended as a preventative measure for women. In men, if you have multiple risk factors, if you're diabetic, you're a smoker, this and this, an aspirin a day may be beneficial, but in women it's not found to be of any benefit. But if you have documented coronary disease, you've had a stent, you have documented that you have heart disease, then you should be on an aspirin a day.
So how about calcium scoring and aspirin?
So that's a very good question. I don't know if there's an answer for that, but I think if my calcium score was over a couple hundred, I would definitely take the aspirin a day.
Thank you.
Because then you are saying that you have coronary disease.
Thank you. Thank you. We appreciate your expert advice to all our viewers. And thank you to all our viewers for watching this episode. If you have any questions, please email us, and we will get back to you during our next episode. Thank you. You have a wonderful day.